Describe and demonstrate the position, features, important peritoneal and other relations, blood supply and nerve supply, lymphatic drainage, and clinical aspect of important male and female pelvic viscera. Explain the anatomical basis of suprapubic cystostomy and urinary obstruction in benign prostatic hypertrophy. Describe and identify the microanatomical structures of urinary system, kidney, ureter, urinary bladder. Describe the neurological basis of automatic bladder. In anatomy, is related to the abdominal organs. Now, urinary bladder. Now, urinary bladder stores the urine and temporarily. Muscles of the bladder contract during micturition. Sphincters function prevents regurgitation of urine in the ureters. Ureteral sphincters help in retention of urine up to micturition. Now, the capacity of the urinary bladder is about 220 ml, and the sense of the bladder filling first starts at 100 to 150 ml. The first desire for micturition initiates at a capacity of 150 to 250 ml. A filling beyond 500 ml causes pain due to distension of the bladder wall. Collection about 800 ml of urine initiates micturition as a beyond one's voluntary control. Now, this is the urinary bladder. We have seen the abdominal cavity and the position of the. Now, this is the peritoneum. This is the anterior abdominal wall. This is symphysis pubis. This is the retropubic space of Retzius. Yes, this is the retropubic space. Now, puboprostatic ligament. This is the prostate. This is the male urinary bladder. Now, the urogenital diaphragm. This is the urethra. Now, seminal vesicles here, the rectum, prostate, urogenital diaphragm, retro-vicycle pouch. Now, location that I told you now. Now, on filling, now in this position, in the difference between the bladder will be there, this prostate, and in the female only the uterus is here. And this is now capacity to 220 ml, empty bladder in lesser pelvis behind the pubic symphysis. Full bladder reaches up to the umbilicus behind the anterior abdominal wall. Now, parts: empty bladder, apex, base, and neck. 3 surfaces: superior, 2 infralateral, 4 borders, 2 lateral, 1 anterior, 1 posterior. Now, at 100 to 150 ml, sense of bladder filling, 150 to 250 ml, first desire for micturition, more than 500 pain, 800 ml involuntary micturition. In children, the bladder is an abdominopelvic organ even when it is empty because of smaller pelvic cavity. In children, the neck of the bladder lies at the level of the upper border of the pubic symphysis. The descent of the bladder begins after birth and continues up to puberty. It's a repetition. Now, hold anatomical position. Hold the cadaveric bladder in such a way its apex is directed upwards and the base is directed posteromedially. Triangular superior surface faces upwards and narrow neck of downwards. Convex infralateral surface are faced infralaterally. Face the palm with while holding in the hand. Now, part of the bladder, the full bladder is ovoid in shape and it has the following parts: apex is directed upward towards the umbilicus, apex, neck, and 2 surfaces. Anterior surface faces towards the anterior abdominal wall and the posterior surface faces backwards. Here's the picture. Now see medial umbilical ligament obliterated urachus. This is the apex. This is the ureter. Median umbilical ligament obliterated urachus, ureters, and posterior surface the base, the neck, the prostate. This is the infralateral, and this is the neck. Now this is the sometimes the urachus does not obliterate. So there is a complaint by the mother that urine is coming out from the umbilicus. Now one thing is that and in that condition you have to wait and see, do an ultrasound, and also you can do a dye radiograph. And if you feel that it is becoming intractable, it doesn't collapse or regular infection, then you have to go for an operation. The same story is the ureter. This is the posterior surface. This is the superior surface. This is the infralateral surface, posterior angle, posterior part of the urethra. Now you see the base. Now the median umbilical ligament, the anterior border, infralateral surface, neck of the bladder, urethra, the ureters, base of the posterior surface, inferior surface. Now this is the posterior aspect of the urinary bladder. See the ureter, this is the seminal vesicles, this is the prostate, this is the bulbourethral or Cooper's gland, bulbourethral gland or Cooper's gland. It's a male urinary bladder. Now, the umbilical ligament, medial umbilical ligament, is remnant of obliterated urachus. Base, in the male, the upper part of the base is separated from the rectum by the retro-vicycle pouch. Contains coils of intestine. The lower part of the base is related. A pair of seminal vesicles, ampulla of vas differences. The vas difference lies medial to the seminal vesicles. The triangular area of the base between the two vas differentia is separated from the rectum, the recto-vesical fascia. Denon-villus fascia, fusion fascia of recto-vesical pouch. Now, in the female, the base is separated from the uterine cervix by vesico-uterine pouch. Vesico-uterine pouch. Now, infralateral surface. The infralateral surface slopes downwards, forwards, and medially and meet each other in the midline at the anterior border. The anterior border extends from the apex to the neck and separates the two infralateral surfaces. Infralateral surfaces are devoid of peritoneum. Now, the relations, these surfaces are related to one retropubic pad of fat, this part, the symphysis pubis, puboprostatic ligament, and obturator internus muscle and levator ani muscles. Levator ani, and this is the prostate outline. Now, see, this is the peritoneal cavity, green, the peritoneal cavity. This is the prostate, this is penis, this is scrotum, this is symphysis pubis, the catheter, inflated balloon, anterior abdominal wall. Now, if in a Now, if there is enlarged prostate and there is retention, the full bladder will extend up to the umbilicus. Now, you can perform a suprapubic cystostomy by just infiltrating 2% xylocaine. These are the two strap muscles of the rectus abdominis. Now, what you do, the bladder. You have to infiltrate xylocaine. You just infiltrate around. Many things can be done under local anesthesia. Many things, many operations, many simple your repairs. Even if you are a bit daring, you can perform even LUCS. One thing I tell you, then you infiltrate, you just make a small incision like this, and now this is the you take sutures, atraumatic sutures, you prick the bladder and you hold it with your hemostatic forceps. Even you hold it with a hemostatic forceps. You ask your assistant to lift up in the same level, and you make a small incision here, and urine comes out. You put in the Collins catheter. You put this is the now the balloons catheter. Then it doesn't come out. Then you have to just suture complete, and the patient gets relieved. Okay. Now, these procedures you will be doing surgery or any if you are an MO in some remote area, you can perform it. And if you don't want to perform, then you can send to your medical college or big super specialty hospital. But this can be, you can do it in a routine practice. What I want to say that the anatomy there's no much bleeding there, and also it can be infiltrated with 2% xylocaine and you relieve that patient. If at all you don't have the guts or you feel that no, I'll be in problem, then you take a big syringe, 10 ml, even 50 ml syringes are available. You take out the urine by syringe. Then bladder gets to some extent that it becomes empty, at least you can transport at that time to get that patient relief. You have to think of relieving the patient, giving, but this can be done. This can be done. The true ligaments of the urinary bladder in the female. Now, this is the vesicae venous plexus, posterior ligament. This is the uterine cervix. This is the rectum. This is the urinary bladder. Now, lateral ligaments. The lateral and medial ligament pubo-vesical, pubo, the symphysis pubis and the pubis and the urinary bladder, pubo-vesical, and this is the symphysis pubis. Now, this is an enlarged view. You just have to draw this type of figures. Now, the median umbilical ligament extends from the apex of the bladder to the umbilicus, remnant of urachus. Pubo-prostatic pubo-vesical ligament, two medial and two lateral pubo-prostatic ligament, and ligaments extend from the neck of the bladder to the symphysis pubis and the anterior end of the tendinous arch of the pelvic fascia. Lateral ligaments, right and left, extend from the infralateral surface of the bladder and to the tendinous arch of the pelvic fascia. Posterior ligament, right and left, and extends as a loose areolar tissue sheet from the base of the bladder to the lateral pelvic wall. They enclose the vesical venous plexus. The umbilical fold is of the peritoneum that covers median umbilical ligament. Medial umbilical folds, right and left, cover the obliterated umbilical arteries, right and left. Lateral false ligament extends from the bladder to the lateral pelvic and from the floor of the paravesical fossa. Posterior false ligament, right and left, are sacrogenital folds and extends from the side of the bladder posterior to the third sacral vertebra. They lie on the either side of the rectum. The inner surface of the bladder, interureteric ridge. This is the ureteric orifice, the ureteric fold. This can be viewed with a cystoscope. It will be clearly seen. You can view it. And your now this is the urethra, this is the seminal colliculus, prostate, urethral crest, external urethral sphincter, and perineal membrane. The interureteric ridge, bar of Mercier. This is known a trigone of the bladder. This is the ureter, ureteric fold, ureteric orifice. The ureteric urethral ridge, Bell's bar. Now prostate, seminal colliculus, this is the urethral crest. Now, some interesting facts. Embryologically, the trigone of the urinary bladder is derived from the absorption of the mesonephric ducts, whereas rest of the bladder develops from the endodermal cloaca. Internal urethral orifice is crescentic in section. Ureteric orifices are slit-like openings about 2.5 centimeters from the internal urethral orifice. See, this is the ureteric orifice, slit, it's a slit. This is the ureter. This is the ridge here. Now, blood supply and lymphatic drainage. The urinary bladder is supplied by superior vesical and inferior vesical artery, branches of the anterior division of the internal iliac artery. Principal blood supply. This is the principal blood supply. The superior vesical and inferior vesical arteries, branches of the anterior division of internal iliac. When the dead body is opened in the dissection hall. Please see the relations and also these blood supply. You pick up and see, and the ureter also, how it is going, how it is entering, and what level. You have to see it. Now, principal blood supply. Now, obturator artery, inferior gluteal arteries, and in females, uterine and vaginal arteries. Venous drainage. Venous blood from the bladder is drained by the vesicae venous plexus that is located in the infralateral surface of the bladder in the space of the Retzius. This plexus passes backward in the posterior ligament and finally drains into the internal iliac veins. Lymphatic drainage. The lymphatics from the bladder drain into the external iliac lymph nodes. Now, there might be a patient with hematuria coming to you with inguinal lymphadenopathy. You please look into the complaint is for how many months or days or years, and if she is having episodes of hematuria or not. And always see, when you are seeing a female patient with your abdomen, you see, you must do a speculum examination. Duckbill speculum, that the other day I told you, duckbill speculum. You please see the vagina, see the cervix. If there is any pathology there, you suspect, then you take a papinicular stain, pap stain, you take a smear from the cervix, put it into slides, and then send it for your, if there is any malignancy or not, pap stain, papinicular stain, and see, these are the screening, you are screening the lady, and she complains also that, see, my limb, some swelling is here. Then it might be a lymphadenopathy, or it so happens that sometime, some in the lower limbs, that was an abscess or something. Then lymph nodes are the policeman of our body. Now, the lymphatic system is such that these lymph nodes swell, and or that inguinal lymphadenopathy means cancer. No. It can be some other causes that can happen. But don't ignore the patient signal. Don't ignore. Whatever she gives you, see, a patient, when you ask a question to a patient, then she will speak maximum 1 to 2 minutes. And then he or she will surrender. Ebar apni dekhun. You please see. Sometimes what happens in the clinic, that's why I don't allow the patient party. But I have my attendant. Sometimes a man brings his mother. She is old. She is speaking something. Man tells, hey, why you are speaking some, tell what is your problem. Then what I tell him, let her speak. You have to pick out what she is complaining, and then it is like a strainer. You are preparing tea, you take a strainer. When the leaf and all, everything gets straight, the water, tea, warm water goes down. You have to chakni, aapko cream ko lena hai. And then you proceed with your investigations, hematological investigation, you proceed with your radiological investigation, you go for ultrasonography, whatever things are available. Now, another thing is that many centers are having now cystoscopes. So if you feel that it can be a stone in the bladder, it can be the epithelial papilloma, then you go for a cystoscopy. If there is a small stone, then it can be taken out. And large stones are removed by lithotripsy. The wave sent your stone is broken into dust, and that comes through the thing. If there is a obstruction in the ureter or the vesico-ureteric junction, where most of the calculi get lodged and stuck, you try, if it is not, you cannot take it out, then you put a stent. You put a stent. Now it's a super specialty. Urologists are available, cystoscopes are available in the district hospital and also in many super specialty hospitals. So you can take care of it. Otherwise, if there is an obstruction with the stone, then there will be hydronephrosis or ureterohydronephrosis. Now, this is another interesting fact. Vesical venous plexus communicates with the prostatic venous plexus in male and with the veins at the base of the broad ligament in the female. The superior vesical artery is derived from proximal initial portion of the fetal umbilical arteries. Now, inferior vesical artery commonly arises from the middle rectal artery. Now, innervations of the bladder. Now, write a short note on nerve supply of the urinary bladder. This is a short note. Now, the urinary bladder is supplied by vesical nerve plexus lying on the lateral aspect of the rectum and base of the urinary bladder. It consists of motor and sensory fibers. Now, see, this is the sympathetic fibers T10 to L2. Now, parasympathetic fibers, this is S2, S3, S4, and this is the vesical plexus. The inferior hypogastric plexus, this is detrusor muscle, internal urethral sphincter, external urethral sphincter. Now, this is the pudendal nerve. Now, this is the picture. Now, your parasympathetic, sympathetic and somatic fibers, this is different motor fibers. Now, parasympathetic fibers, nervi originatis, arises from S2, S3 and S4 spinal segments and enter the plexus through the pelvic sphincteric nerves. They are motor to distressor muscles. They do not supply the pre-prostatic sphincter. The sympathetic fibers are derived from T10 to T12, L1 and L2 spinal segments. They are inhibitory to distressor muscles and motor to the pre-prostatic sphincter. Somatic fibers are derived from pudendal nerve S2, S3, S4. They supply sphincter urethra, voluntary control of micturition that is situated in the wall of the urethra. This pudendal nerve. And especially ladies, if they don't find a toilet, they cannot. Now, men or boys, we stand anywhere, we urinate. That's why another thing is that in fear of your finding a toilet, makes the ladies intake of water minimum. And one thing is that, see, you're having, all of you is having some bottle in the desk. What happens? You're feeling thirsty, you are just taking something that will only soak your throat. But what I suggest you have carry a small glass. Take it. Carry in steel bottles or copper bottles, not plastic. Microplastics is a very problematic. And intake of water to your patient, you suggest that you have to drink at least 3 liters. Now, to khai, you ask any patient, no, I drink. How many bottles do you drink? Now, the measurement is in bottles now. They say, wo to pite hai. But you have to educate. At the same time, when you're writing a prescription, you won't, your cystitis, UTI will never this thing. Especially the females have a propensity to have UTI more than males. More than males. Because of intake of water and also holding the urine for longer periods. That's why in marriages, especially in India, there is a trend, ekdam, since our ancestors came into this earth, that they give some vessel, some glass during marriage. But nowadays, washing machine, IFB and dishwasher and this thing, your your microwave and all this. But I tell my patient, hey, তোর বিয়ের গ্লাসটা কোথায় আছে? উপরে তোলা আছে, লফটে. After marriage 1 month, then everything goes on the loft. For what? If you have a child, male or female, you will, if it's a male, you give it to your boma, and you have to bhog karo, you have to enjoy because that is given to you specifically. And this is one thing I'm telling you. You next time, after 10 days, if this patient, hey, rasta bar korechis? I don't say kemon achis. How are you? I don't say. Hey, you have brought down the glass, you are drinking with the lota or glass. This is one thing I tell you. That's very important, I would say, as a medical student. Now, the fibers carrying pain sensation, the anterolateral white column of the spinal cord, the fibers carrying sensation of filling of bladder run in the posterior white column of spinal cord. Here, bilateral sectioning of anterior lateral white column of spinal cord, anterolateral cordectomy, relieves the bladder pain sensation and maintains normal micturition. Now, this, if there's a complaint like this, then this is an operation done by the neurosurgeon. Neural control, write short note on micturition. Neural control of micturition, write a short note on, this can be a small question. The process of micturition involves the following steps. Sense of filling and of urinary bladder, 220 ml, the flow sheet, the chart that has been shown earlier. So this is important. Holding the urine. Now this is holding of urine. Detrusor center of paracentral lobule inhibits the sacral neurons. Lateral horn cells of S2, S3, S4 until suitable space and time available for micturition. That I told you, the holding the urine. So you have to take and voiding or micturition. Voiding or micturition, parasympathetic fibers S2, S3, S4 gets stimulated by inputs from sensory fibers carrying filling sensation. In absence of inhibition from paracentral lobule, these fibers contract detrusor muscle and relax pre-posterior sphincter. Entry of urine in the proximal part of the urethra stimulates the urethral stretch receptors that also send signals to the parasympathetic fibers S2, S3, S4 and inhibits pudendal nerve. Inhibition pudendal nerve causes relaxation of the external urethral sphincter and initiates micturition. Now, the mucosa, urinary bladder, smooth muscle coat and detrusor muscle. Now, serosa and adventitia, connective tissue layer. Inner longitudinal, middle oblique and outer longitudinal. Now, transitional epithelium, umbrella cells may be binucleated, eosinophilic plaque coat, lamella propria and mucosal fold. Serosa only superior and part of the posterior surface covered by peritoneum. Duct, the ureteric bud, urinary bladder. Now, vesico-urethral canal, urogenital sinus, ureteric orifice, urinary bladder, trigone of the urinary bladder, primitive urethra and ejaculatory duct. Now, lining epithelium of the bladder, except the trigone, it is derived from cranial dilated part of the vesico-urethral canal, endoderm. Lining epithelium of trigone is developed from mesoderm by absorption of mesonephric ducts in the dorsal wall of the vesico-urethral canal. Muscles and connective tissue coats, they develop from mesoderm, flancopleuric intraembryonic mesoderm surrounding the vesico-urethral canal. Urachal, median umbilical ligament is derived from allantois. For details, refer to. Now, congenital anomalies of the urinary bladder, fistulas, congenital retro-vicycle fistula, it develops due to incomplete urorectal septum. Congenital vesico-vaginal fistula, Mullerian eminence is elevation in dorsal wall of the phallic part of the urogenital sinus, formed by fused caudal end of the paramesonephric duct. If Mullerian eminence projects into the vesico-urethral part of the cloaca, it results in vesico-vaginal fistula. Urachal fistula is persistent allantois. In this condition, urinary bladder communicates with the exterior at the umbilicus. Urachal cyst develops from non-lobulated middle part of the allantois. It forms the palpable midline cystic part of the anterior abdominal wall. Urachal sinus develops from the non-obturated distal part of the allantois trunk that shows opening at the umbilicus. These things are very common. This is common. Common means it is not one case every 100 babies are born. It's not that. At least 5,000 to 10,000 babies. Then there will be your urinary bladder, urethra, this is the urachal cyst, median umbilical ligament. This is you do an USG, you will get it. The photograph, there will be a swelling in the baby, a small swelling in this portion. Then you, how will you know that it might be swelling? It can be a small hernia also. So you have to make the difference. And by the feel, and your hernia will go inside. So the cyst will be in a position. Hernia, the baby is crying, then it will come out. It will swell up, umbilical hernia or some portion of the. But if it is a urachal cyst, then the swelling won't collapse. So you are sure that it is the urachal cyst. Urachal cyst actually, at least in my practice, I have not come across. But fistulas, sinuses, I have come across. This is hourglass bladder. Now, hourglass bladder, in this condition, urinary bladder is divided into upper and lower compartments by a constriction in the middle zone, this hourglass. Now, ectopia vesicae, it is also called extrophy of the urinary bladder. It represents the deficient midline umbilical part of the anterior abdominal wall, deficient anterior wall of the urinary bladder, exposed interior of the bladder, and dribbling of urine from the exposed bladder. Embryological basis, it occurs due to failure of complete formation of lateral fold of embryo and failure of migration of mesoderm in the lateral fold. This is the examination of interior of the urinary bladder. Trabeculated bladder, it occurs due to chronic obstruction to the outflow of the urine. Prostatic carcinoma, in this condition, the bladder is hypertrophied and the muscles increase in size and give rise to open V or trabeculated appearance to the bladder wall. Urinary stones, urinary bladder is a common site for formation of urinary stones.